Welcome to Issues. We're pleased to have you this evening. Hopefully a few weeks ago you saw our Father's Day program, and at the end of this evening program we're going to show a small clip from the Father's Day program, and I think it is something that we really want to bring to your attention. Well, I'm very excited about this evening. We have one of my doctors who is here with us. Dr. Warner is here with us this evening. Now, I am a cancer survivor. I had cancer, I think colon cancer, back in 2003, 2004. And this coming July, in a few weeks, Dr. Warner is going to perform his third colonoscopy on me. Now, Dr. Warner, what leads up to colonoscopy? Why a colonoscopy? What's the rationale?
Well, Richard, colonoscopy is a technique for examining the colon and in visualizing the architecture and the anatomy of the colon. And why we want to do this is that colon cancers begin as polyps. And polyps can remain in the colon for very many years, 5, 10, 15 years, growing slowly, progressively over time. So there's a great window of opportunity. So before someone has colon cancer, for the most part, if you look back, they've likely had a polyp sitting in their colon going back 5, 10, sometimes even 15 years. If we can intervene during that period at the polyp stage, we can actually prevent the person from having colon cancer. And so it's a great technique for diagnosing and treating the cancer before it becomes a cancer.
Now, having said that, is there a particular age that you would recommend for someone to have a colonoscopy?
Well, the generally accepted criteria in North America is age 50 for the general population. Mm-hmm. That can vary depending on one's circumstances. If you have a strong family history of colon cancer, particularly if the colon cancer has occurred in first-degree relatives, say parents or siblings, at a fairly young age, meaning you say younger than 60, then we sometimes recommend the first colonoscopy being performed earlier. So let's say if you had a father who had colon cancer at 50, was diagnosed well, then our recommendation would be that you would have a colonoscopy 10 years before that age, so at age 40, because we want to be able to catch the disease process at an early stage. And it can be treated with local therapy.
And that's exactly an experience that I've had. My father had colon cancer. I had colon cancer, and my son, who's only 38, had a colonoscopy when he was 30, just to be sure. Fortunately, there were no polyps. Now, let's talk about these polyps. Where do they come from?
Well, that's the million-dollar question, Richard. No one, I'd have the Nobel Prize if I could tell you that answer. But you know, what we understand about it, and this is called the polyp hypothesis, is that polyps arise from cells, single cells, that grow and multiply under the influence of one's genetics and one's environment. There are certain conditions, familial polyposis syndromes, where persons produce multiple polyps, sometimes hundreds of polyps. And if you have this syndrome, you will develop colon cancer at an early age, usually in the 40s. But if you look at the total population of colon cancer patients, patients with that syndrome represent probably 1 in 1,000, so very little. Most of the other patients, in fact, have what we call episodic colon cancers, and we don't really understand exactly how they come about. We know that there are certain risk factors. Age is the first and greatest risk factor. The older one gets, the higher the incidence of colon cancer. So as you move from your 40s, colon cancer is very low in that age group, to your 50s and your 60s, it really kind of peaks in 70s. So the incidence triples between, say, 40 to 50 and, say, 60 to 70. So the incidence actually triples. So as you get older, your rate or incidence of colon cancer increases fairly dramatically. But there are other risk factors. Obesity is one. Cigarette smoking, which is a culprit for many medical conditions, is a risk factor. Inactivity, diet as well. You know, the diet that is high in fat, high in animal fats in particular. of interest, studies done in the U.S., longitudinal studies, have shown that persons who are vegetarians, lifelong vegetarians, actually have a much lower incidence of colon cancer, regardless of their genetics. So certainly there seems to be more than one factor, the genetic factor and then the environmental factor that interplay to cause this abnormality.
Now, polyps, are all polyps cancerous?
No, all polyps are not cancerous. In fact, polyps invariably start out as being non-cancerous. But as they grow and as the cells in them divide, something seems to happen. By the time a polyp in the colon reaches the size of approximately 2 centimeters in diameter, which is less than an inch, it has about a 40% chance of having inside of it cancer cells. If the polyp reaches 3 to 4 centimeters in size, then the chances of that polyp containing cancer is about 60%, 70%. The cancers typically start in the head of the polyps. Polyps are little mushrooms, so you can think of the head of the mushroom. The cancer cells start there, and then they slowly sort of replace the normal cells, and they grow down the stalk of the mushroom or the polyp, and then invade the actual wall of the colon. Once they reach that stage and they invade the wall of the colon, you have frank colon cancer, and the treatment then has to be a resection of part of the colon to ensure cure. If one detects the polyp at an early enough stage, in fact, even quite a large polyp, if you resect the stalk and if you examine the stalk under the microscope, or the pathologist will do that, and find that the stalk is clear, then the treatment is complete.
Okay.
So you can actually resect polyps that have cancer in them, and there won't be any need for external cutting surgery.
Now, as we look at colonoscopy, are there any preliminaries to colonoscopy? If you're going to perform a colonoscopy, what type of preparation needs to be done prior to the person coming in for the procedure?
Right. Well, as we use light sedation, we like to know that the patient is in otherwise general good medical condition or stable medical condition. So we like to make sure the lungs and the heart are in fairly good condition. They can tolerate a light anesthetic. And we use a very light anesthetic, typically something called propofol, that will put you to sleep very quickly, but it has a very short half-life, so that it wears off very, very quickly as well. So you're asleep for the entire procedure for maybe 15 to 20 minutes. You wake up and there's very little hangover, and you feel like you're good to go right afterwards. So that's the first thing. The second thing is that because we're going against the natural flow, when we do a colonoscopy, we start at the anus and the rectum and work our way proximally. We need to clean the colon out. So the colon has to be properly prepared. And to do that, we use a combination of laxative solutions that one would take the day before. So typically, one would be on a clear fluid diet the day before the procedure, and then in the evening, you would have to drink a special balanced electrolyte preparation. Now, this preparation isn't absorbed into the bloodstream, but just flows right through the gut, from the mouth to the stomach to the small intestines and to the colon, and basically kind of just washes everything before it. The preparations are typically 2 liters to 4 liters that one drinks over a course of 3 or 4 hours in the privacy of your home. And typically we start at about 6 o'clock in the evening, so you can work that day but not have solid food. Go home at 6 o'clock, begin the bowel prep, and that's finished typically by about 12 o'clock. And you'll have typically 5 or 6 bowel movements that will become increasingly watery and loose. And then by 12 midnight, you're finished, and the next morning you report to the hospital, to the operating room and the endoscopy suite, and you have your procedure. Yeah.
Let me tell you, the sleep that I've had, I don't know if it's called sleep, but the sleep that I've had during a colonoscopy, that was one of the most restful sleep I've ever had. I hate to be awakened after that because it's a very restful sleep. Now, as with any type of procedure, what type of dangers could occur?
Well, with any type of procedure, there is a risk. There's an anesthetic risk that's inherent with any anesthetic procedure. One can aspirate, meaning vomit contents from the stomach up into the lungs. That's, in fact, very rare, exceedingly rare. The other risks are really attendant to the procedure itself. There's a risk of bleeding that can happen, that usually after biopsies or after polypectomies. It's after we cut polyps out, then one can sometimes bleed later the next day. If you bleed at the time, then that can be very easily controlled endoscopically. So bleeding is a risk factor. Perforation is a risk factor, again, associated with biopsies or polypectomies for the most part. Occasionally, patients can have very severe diverticular disease, which is independent of polyps, and that can present a real risk and a danger for doing the colonoscopies, as the colonoscope can sometimes push its way through a diverticulum and cause a perforation. The major complication rate it approaches 1 in 1,000 procedures. As patients get older, and if you just look at patients who are having, say, biopsies and polypectomies, then the complication rate increases to about 7 in 1,000, but still very low, and still most of the time they can be controlled locally.
Well, very good. Now, we've been talking with my doctor, who will be performing a colonoscopy on me next month. Just one last question, Dr. Warner. After the procedure, can one just get in their car and drive back home?
No. As a safety measure, we ask patients not to drive or ride or operate any heavy machinery for the rest of that day. But the next day, you can resume activities as normal. You can eat, actually, once you finish, and all after you finish, you can eat, you can go shopping, you can even go back to work if you like. But most people feel a little tired, and as you said earlier, you get a really, really good deep sleep, and you think you've been asleep for hours, but it's only been 15 minutes. We like to say the Michael Jackson sleep.
Yeah.
But you can certainly resume activities except for driving that day, and you're good for work or school the next day.
Okay. Now, Dr. Warner pointed out that the typical age for the colonoscopy is 50 years old. But if you have had a history of colon cancer in your family, then you would need to have it around age 40 or so. Is that what you said? Yeah.
Right, exactly. And if I could say something else, there's been a move afoot in the U.S. to recommend, and this hasn't been official as yet, to recommend that people of African descent, or African Americans, have their initial colonoscopy, in fact, at an earlier age, at 45. And that's because the incidence of colon cancer in African Americans is about 20 to 25% higher than in non-African Americans in the U.S. for some reason. Also, the rate is 20% higher in males versus females. So if you are an African American man or a man of African descent, then you are actually at the highest risk for colon cancer in Bermuda.
Yeah. We've been talking with Dr. Wilbur Warner, internist, and my doctor who's going to do my colonoscopy next month. We will be right back with our next guest. Welcome back. We're now going to have a discussion with Dr. Royland Sams, optometrist whom many of you go to. Dr. Sams, we're happy to have you with us.
Thank you.
Dr. Sams and I share a little bit of history, years apart. Both of us went to school in elementary school in Montreal, Canada, and both of us had the same teacher who made a tremendous impact on our lives. I was several years ahead of him, but we still have the same teacher. So
Yes.
It's good to have you, Dr. Sams.
Thank you.
Now, one of the questions I'd like to ask you, what is the difference between an optometrist, ophthalmologist, and an optician?
Yeah, very good question, which, quite frankly, I get a lot. Bermuda, there's a lot of confusion on the definition between those three because Bermuda is a little bit different than some of the jurisdictions where it's a little more clear-cut. Here in Bermuda, generally speaking, you can say that the optometrist is similar to your GP for eye care. So in other words, the majority of primary care issues, the general sorts of stuff, all right, the optometrist will manage, and that can venture into, health maintenance issues with the eye, medical issues, if you will, as well as the glasses, the contact lenses, and the things that are more familiar to people. The optician, on the other hand, which is kind of loosely used to refer to an optometrist at times, but is really actually incorrect, because the optician is actually more someone who functions in the mechanical function of making of the glasses and so forth. But given the influence of the UK, where that term and optometrist is used very interchangeably, there's a little bit of confusion there. The ophthalmologist is one who crosses over on many of the things that optometrists may do, but of course, is generally speaking, you consider the specialist. Yeah.
So most people, in terms of eye care, would go to an optometrist.
Right.
Okay.
That's correct.
Okay. Now, what sort of educational preparation is necessary?
Sure. Well, depending on the school or the country even that we're referring to, but where my experience is from, of course, would be in the United States, where it's normal to have a 4-year undergraduate degree, followed by 4 years of optometry school. Some programs may require residency thereafter. Most do nowadays, actually. So in total, at least 8 years.
Yeah. So the optometrist, his or her education is equivalent to a medical doctor.
Well, I mean, there are some differences, of course, but I use the analogy, it's a little more akin to, for instance, the dentist, because the length of time and so forth. At Ohio State University, where I did optometry school, for instance, the vast majority of the lower level classes, the pharmacology, the physiology, all of those are actually common between the dental school, the optometry school, and the medical school. Same teachers, same notes, same everything. But in the second 2 years of your program, things start to branch out and specialize quite a bit more.
What made you choose optometry?
Yeah, I wish I could say there was, the maiden from the pond came forth and told me, but actually, I think it was a career expo at my church where I first heard of it. I think I was perhaps in middle school age, around there. Didn't really make a big impression, but I thought, okay, it sounded interesting. But actually, when I attended Atlantic Union College during my sophomore and junior year, there was another career fair that happened, and some people from the New England College of Optometry came, talked to me about it. I got an increased interest, and I had it shortlisted. And amongst many other professions I was interested in, but it ultimately came down to optometry as a good balance between all the benefits of a medical career without some of the downsides, being on call and some of those sorts of things.
Now, how frequently should one come in to get their eyes examined?
Not an easy question to answer succinctly. Generally speaking, for those who have no significant health risk factors, they don't have anything unusual going on. I think for most of us in between our 20s and 40, it's certainly reasonable, 2 years. I think some might say even 3 years. I think anywhere in there, if you don't have any risk factors, is fine. Once you cross over that in increasing age, we tighten that up a little bit, 1.5 years, 1 year. And younger, of course, we certainly recommend annually during the school age years because a lot is changing.
When one comes to an optometrist, does he or she, can they detect glaucoma?
Yeah, glaucoma, yes, it would be a normal part of what we'd be looking for along with really any form of eye disease.
Now, what exactly is, pronounce it for me? Glaucoma.
Right.
What exactly is that?
Glaucoma, the definition of that has changed a little bit. I think many still think of it as a disease primarily of increased fluid pressure in the eye that then damages the nerve, the optic nerve at the back of the eye. And so it results in a painless loss of peripheral vision initially. So you kind of lose your side vision, and as that tunnel vision effect increases, then ultimately the central vision goes as well. But there's no sign or symptom. There's no pain. There's nothing. You could be 20/20 vision because it's taking the side vision away first.
Now, is that only detected when one comes to you for the examination, or as an individual, will I notice some things happening?
Yeah, sure, you'll eventually notice, but unfortunately by the time you can actually detect yourself that you're losing your sign, well, you've lost in the neighborhood of about 60% of your nerve tissue permanently, so it's that you can't turn that back. So that's one very good reason to be checked regularly, especially for those over the age of 40, especially for those who are of African descent, who have a much higher risk of glaucoma.
You know, Dr. Warner in our opening session talked about the risk to African Americans and black folks, and you're saying the same thing. Yeah. My goodness gracious.
Yeah, taking it on all sides.
Yes, we sure are.
Yes.
Now, in terms of eyeglasses versus contacts, is one better than the other?
It depends on your prescription, but for most of us, glasses are lower risk, of course. A contact lens is essentially a prosthetic. It's a medical device that's going onto a very, very delicate tissue, being your cornea. So there's some risk involved. So, you know, no matter what, to me, the preferable choice is to go with whatever's lowest risk. From a performance standpoint, if you have a very high prescription, you know, thick lenses, then contacts are clearly better from a cosmetic standpoint. You don't have the weight of the glasses. And if you're highly nearsighted, because the lens is on the eye, it tends not to shrink or minify what you see. So for people who are highly nearsighted, they can actually see a little bit better with contact lenses as opposed to glasses.
So it's one factor is that it's cosmetic. I guess people think that make them look better.
Right.
And the other factor, you say, if you have a real high prescription, then you don't see those thick Coke bottle type glasses.
Right, exactly. And we use them, contact lenses, for many other purposes as well, therapeutic purposes also. You know, for instance, people who are post-surgical, where they've had grafts, you know, corneal transplants. People who are suffering from diseases like keratoconus, which is unusually common in Bermuda, where we need the contact lens to actually give proper vision because glasses don't work in those situations. Yeah, so they have to wear a contact lens.
Wow. Now, there's a lot of television watching today. Is there recommended distance one should sit, especially children, should sit from the television set?
Right. Yeah, I guess in the old days, people used to say, oh, well, you get radiation and whatnot if you're too close to the television, which is, you know, was not true then, and it's actually definitely not true now. However, depending on whose numbers you quote, there's a lot of standards out there. Anywhere from, you know, if you take the diagonal dimension of the television, so if you say a 50-inch screen, you know, that's the measurement across the screen, anywhere from 1.2 times that size is the distance that you should be in inches, upwards to some even say 2.5. Most people quote, certainly professionals in home theaters and whatnot, they will tell you 1.6 times the size of that. Otherwise, if you're too close, you actually see the little pixels in the screen, and it can lead to eye strain and so forth.
Eye strain. So one of the dangers in sitting too close is eye strain, which would lead to what?
Well, I mean, it's not going to physically harm you in any way, but certainly, you know, headaches, eye fatigue, you know, it's just uncomfortable. Yeah, but it's not going to harm you physically.
When one comes into you for an examination, what are several things that you're looking for?
Well, I mean, almost anything, certainly. We look at eye care as a part of the person's general medical health. Your eyes are connected to your bodies, and for that matter, it's directly connected to your brain. And so there are common vascular pathways leading to the eye and to the brain. And so what we see in the back of the eye, looking at the retina, for instance, we're in a unique position amongst professions to see how healthy those blood vessels look. So picking up on undiagnosed hypertension, diabetes, just a range of conditions, because many things affect the eye as well.
Diabetes is something that can be detected from eye
certainly, if somebody has uncontrolled diabetes, you're going to see signs in many different parts of the body, and one of them happens to be the retina.
Wow. Yeah. Now, when I get my eyes examined, there is a little puff of air that comes into my eye?
Yes.
What are they looking for when they do that?
Well, it's measuring eye pressure. It's measuring the internal pressure in the eye. And some people call it a glaucoma test. That's probably overstating its importance, but it's measuring fluid pressure of the eye.
Okay. Back to the contacts. If someone sleeps in their contacts, are there any dangers to that?
Yeah, oh, definitely. You're taking the risk of infection, of course. You are running the risk of corneal erosion because you're not tearing when you sleep, so that lens is drying out on the eye. You wake up, try to remove that lens, take it off, anything like that, you can cause an erosion which is quite painful. But more importantly than that, your cornea can't breathe. It's a very oxygen-sensitive tissue. It will swell even under normal circumstances. So you leave this thing on around the clock, you're going to run into a host of problems. Plus the buildup on the lens, they're not getting cleaned. So your risk of complications is anywhere from 5 to 15-fold increased by sleeping in lenses, even with the newer, more breathable lenses.
That was going to be my next question, because there are television commercials that kind of suggest that you can sleep.
Yeah, they overstate it quite a bit. I mean, there's still a myriad issues that are not resolved by just making it more breathable. So it's still something to be very cautious about doing, and we really rarely do it unless it's really warranted.
One of my last questions. Parents, what are some symptoms they would see in their primary school children to know that maybe there are some problems with the eyes and need to take them to someone like you?
Sure. Well, first off, what's most important is that we actually recommend having children checked, a full proper eye examination before they start school. So somewhere between ages 4 and 5. We can see children earlier than that, of course. Between the pediatrician and what we can do, certainly you try to catch some of the major issues, but the first eye exam should certainly be between 4 and 5. 80 to 85% of your learning is visual. So certainly if parents are finding their child is underperforming, looking for things like eye rubbing, squinting, favoring one eye or the other, head turns or tilts, eyes that seem to wander or drift, fatigue, falling asleep while reading, complaints of headaches, especially in the forehead area. There's just all sorts of things to look out for. But quite often I find, mom is usually the best detective at finding these things. But regular, consistent eye examination for children is a must.
Yeah, and as young as 4 and even younger than 4 years old.
Yes, that's correct.
We've been talking with Dr. Sams, and one of the things that sticks out in my mind that he has said is sleeping in contacts, your contacts is not really the healthiest thing. I don't wear contacts, but I know many people who do wear contacts, but try your best not to sleep in your contacts. Dr. Sams, thank you so much for being with us.
Thank you for having me.
And we will be right back with a clip from our Father's Day program. Welcome back. We're so happy that you could join us for our Father's Day special. Earlier in the program, we spoke with Calais Darrell, and we have her back again. Besides Calais is her mother, Verona Darrell, and you heard Calais speak so eloquently about her mother. Now, I have a very special and very important question to ask you. You are a patient at the dialysis clinic here in Bermuda. So what is that special need that you have?
I've been on dialysis since November of last year, and I need a kidney. I'm young, so it's not really fun to have to do dialysis for 3.5 hours. And I'm currently on the list for a transplant, but the hospital says, better if you can get a live donor and things like that. So that is my need, my want, and really soon. Yeah.
Okay, and we're going to ask, if you would like to know more about donating a kidney to Calais, you can contact her by going to our website, issuesbda.com. issuesbda.com. And again, you've heard the need of Calais, the need of a kidney. An extremely young lady, very talented, and she needs a kidney. So again, you can contact us through issuesbda.com. We'll put you in contact with Calais and the medical team.